Palliative sedation is the administration of sedative medication in order to resolve or alleviate refractory symptoms at the end of life. A symptom is considered refractory when maximal conventional therapies are either unable to provide effective relief or incapable of providing timely relief. Terminally ill patients with burdensome symptoms are likely to benefit from palliative sedation. Recent studies have shown palliative sedation is safe and does not accelerate death. Informed written or verbal consent must be obtained from the patient or legal representative prior to initiating palliative sedation therapy. A detailed goals of care discussion should address what therapies will be added or continued, which will not, and why. For example, artificial hydration and nutrition are usually inappropriate in this phase. Also, clinicians should clearly explain prognosis and life expectancy. In order to avoid misunderstandings, the whole team should have previously discussed prognosis and goals of care. All should be in agreement on the indication that it is time for sedation and can identify and assess whether goals of sedation are being fulfilled. Palliative sedation can be administered either intermittently or continuously. Intermittent, also referred to as respite sedation, is the temporary administration of sedative agents to relieve symptoms for a predefined period of time with frequent reassessment. This typically occurs over the course of 12 to 24 hours. Sedation is then decreased until the patient is either fully conscious or symptoms relapse. In the latter, sedation is reinitiated. Respite sedation can be useful for quick relief as other, longer-acting measures for symptom management become ineffective. Continuous sedation is where there are no planned periods of interruption. Whenever possible, family presence is desirable while initiating continuous sedation. Medications for symptom management that were prescribed prior to palliative sedation should be continued, unless they are proven ineffective or have distressing side effects. Palliative sedation is most often performed in a hospital setting. However, it is feasible to be, and has been, studied and performed in a home setting, which may be preferable for a subset of patients. Midazolam is usually the drug of choice because it is a cheap, fast-acting agent that can be used via oral, subcutaneous, and intravenous route. A bolus dose of 2.5 to 5 milligrams is administered for quick relief and can be repeated every 5 to 15 minutes until the patient is no longer agitated or no longer shows nonverbal signs of distress. Lower doses may be considered in the extremely elderly, cachectic, or frail patients. Bolus dose is followed by a continuous IV infusion of 0.5 to 1 milligram per hour, titrated to patient's comfort. Doses up to 20 milligrams per hour have been reported. Some antipsychotics, such as chlorpromazine and barbiturates, and other sedatives, such as propofol, can be used as alternatives to midazolam. The clinical parameters that must be monitored and observed closely are patient's complaints, dyspnea, and signs of nonverbal pain. Routine monitoring of vital signs can be disturbing and not useful at the end of life. Once initiated, sedation is usually not titrated down, unless it was prescribed as respite sedation. Palliative sedation is an important resource that can improve quality of life, provide pain relief, and preserve patient dignity. It should be considered whenever a terminal patient has intolerable or refractory suffering.
So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to register for a free trial account which will give you access to selected chapters of the course. If you want to learn how MedMastery can help you become a great clinician, make sure to watch the About MedMastery video. So thanks for watching, and I hope to see you again soon.